Very good morning, everyone. Thank you for this opportunity. As Neil kindly introduced me, I'm Vibhor. I'm one of the founders of Pangea, based in London and San Francisco. We provide a software product to clinicians in the healthcare and the pharmaceutical industry to help them characterize patients across 4,000 different hard-to-diagnose conditions without touching or moving the data. The UK's Department of International Trade awarded us as Digital Solutions winner for this year. And Microsoft made us a top-tier partner this year, which is exclusive for 30 of the 30,000 companies that they work with globally. By way of background, I come from oncology, trained 21 years ago, and my co-founder, Professor Guo, has been in computing for 35 years at Imperial College. We've raised more than $200 million through our research, and we're very proud to have experts like Lord David Pryor, former chairman of NHS England, on our board, amongst other leading lights who you can see on your screen. The problem we solve for characterizing patients really stems from the fact that for characterizing patients, clinicians need access to intelligence from relevant patient records. And it's lack of access to such intelligence, unless clinicians do so manually, that leads to more than 60% of the patients not being characterized properly and therefore not being diagnosed in a timely manner. Pfizer published a peer-reviewed publication last year where they showed how, due to this lack of access to intelligence and poor characterization of patients around non-valvular atrial fibrillation, an overhead of $13 billion was recorded annually in the US alone. And similarly, for cancer-associated cachexia, the overhead was about $1.5 billion or 1 billion pounds in the UK. Hence, we built a product to solve this problem by being able to access intelligence in a scalable and a privacy-preserving manner, thereby leading to successful patient characterization. We have a few success stories across healthcare in the UK and the US. For example, clinicians have used us to reconcile ICD codes, which have proven to be wrong more than 50% of the times. Working with NHS in Edinburgh, we've found 6 times more undiagnosed, misdiagnosed, miscoded cancer patients with cachexia, which led to the halving of treatment costs from £10,000 to £5,000. And given that there are potentially 200,000 patients in the UK, could lead to a saving of around £1 billion in the UK alone for just one disease. Similarly, British Medical Journal published our work 2 months ago, where they showed how by being able to characterize patients, we were able to predict length of stay and risk of mortality for patients in ICU with 85% accuracy. And finally, working with Roche and Genentech, we showed how by being able to characterize patients, working with some NHS data and data from the US, we were able to find 5 times more suitable clinical trials compared to standard NLP or information retrieval-based approaches, but equally how we were able to summarize the knowledge for characterizing patients in the form of a human readable narrative that could go directly into regulatory reports and for FDA. With that, I would like to thank you all for your attention and happy to take any questions.
We'll take the questions in the order that the judges put their hands up, and first one, hot off the mark, is Joe.
Hi, Vibhor. Thanks so much for that great summary. Obvious question, but commercial model, how are you? Well, if I'm allowed 2 questions, one is around commercial model. The second is slightly more sort of theoretical, but where does characterization end and personalization begin? You know, have you found through the early trials that you're bumping into any efforts around personalization?
Absolutely. Thank you, Joe, for those questions. I'll start with the second one first. So you're quite right. Characterizing patients for clinicians is no different when it comes to preventative health or precision medicine. We have shown that in the work we did around cancer-associated cachexia, which was actually motivated by pharmaceutical companies, 2 pharmaceutical companies, one of who already had a drug on the market in the UK for treating such patients, and the other who were looking to start a major clinical trial in the UK and the US. But when we talked to oncologists in Edinburgh, they said these are terribly hard to diagnose patients. More than 50% of cancer patients suffer from cachexia, we know that. But about 90% of them are underdiagnosed because we can't weigh everyone and we can't record BMI for everyone. So if we could characterize these patients earlier on and find them earlier in their journey, then of course we have the opportunity, to your point, for precision medicine, connect them to the nutritionists and of course provide them the right therapy, which can be quite different if you are just providing the usual cancer care, following the usual cancer care pathway. And as we showed in the publications, it's because of that precision medicine approach that followed they are now able to reduce the cost of treatment from 10,000 to 5,000 pounds. In fact, in collaboration with 5 other trusts, they're taking the project further, where now instead of retrospective data, they're now using prospective data, which they're capturing in order to find these patients earlier.
Okay, thanks. And quickly on commercials.
Oh, yes, excuse me. A commercial model, we sell the license to the product, which is computed based on the number of records that we process, which is allow us a repeatable sales process, because this work takes us about 6 to 8 weeks only to do. And as you can appreciate, pharmaceutical companies and healthcare providers who are sponsoring this work are using the product for characterizing patients across multiple different hard to diagnose conditions, as opposed to them installing 200 different apps for 200 different conditions.
Okay, thanks.
Thank you. Next is Rod.
Hi there, Rod Joyce, Deputy Director of Innovation, NHS England. I guess my question's kind of commercial based, but it was kind of like, where does this fit in the NHS, right? So, I can see that there's a need at primary care, secondary care, social care level, but the data is so disparate across those areas. Where do you, I wish it was different. Where do you see it fitting, particularly in context of some of the work that's happening around like the federated data platform and things like that? Where do you see yourself fitting now and in a few years' time?
Great question, Rod. So in fact, we are part of the federated data platform exercise. We've been involved with the team with pleasure for over the last 2 years since they started ideating it. And as you can see, the 5 use cases, the principal use cases which the federated data platform is based on around care coordination, elective recovery, and pathway management fit squarely with what we talk about in the context of characterizing patients. Because characterizing patients is central to everything we do. It's the root. From there, you then look at clinical decision-making, you look at you look at pathway management, you look at resource planning, as we showed through the ICU study. Because now you can predict prognosis in these patients and you're able to predict the length of stay. You can plan for your resources better, as these clinicians show, right? So we are a step before clinical decision-making, because given my medical hat on, I don't think clinicians like using a software for clinical decision-making, but they certainly like the capability to have access to intelligence at scale, which can then allow them to make decisions quickly. I mean, take, for example, one patient record on average is about 1,000 pages. It takes us about 30 to 40 minutes at the minimum to go through that. If you can have access to intelligence beyond just saying, let's do some NLP and look for specific symptoms, and actually that intelligence in the context of what's written in the record, then you can really demonstrate power in terms of knowing what's going on with the patient. And for that, we have a few success stories that I shared here.
Brilliant, thank you. Next is John.
Yeah, thank you, Vibhor. I think it's like a really clearly defined sort of patient segment. You sort of mentioned 200,000. What have you achieved in terms of patient numbers so far, and what's sort of driving the cost of what's driving the cost saving? Is it labor? Is it treatment spend?
Exactly. So I'm just going to go quickly to the slide, not to take too much of your time. This is the kind of knowledge graph that helps us characterize these patients. But we started off, John, with a data set of 8,000 cancer patients in total. And there, if we were to use search just for cachexia or patients who were cachectic based on ICD codes, or based on just using symptoms like weight loss, malabsorption, using generic NLP approaches, as you can see, we would have found only 51 such patients. But when we applied our product and characterized these patients in the same data set, we found about 316 such patients. So hopefully that gives you the measure of scale. Now, in terms of savings, these savings are really coming from, because if these patients are not being identified as cachectic, as I was discussing earlier, the treatment care pathway is very different, right? They're not being connected to the nutritionist, and the treatment care pathway is different. As a result of this, their outcomes are not improving. In fact, in most cases, they're becoming worse. I mean, 20% of cancer casualties are due to cachexia, unfortunately. So you can see that if they're getting worse, then that's a bigger burden, especially on a system like the NHS, and they're staying in the hospital for longer and so on and so forth. So what the clinicians have shown who are practicing, they showed that the halving of treatment costs was due to a combination of factors of that, including resources and, of course, treatment costs as well.
Thank you. Sarah, I think you're next.
Thank you, Vivna. I'm Sarah Nelson, Programme Director at Digital Health London. Really interesting to hear. I'm wondering, and I've changed my question since I put my hand up based on some of the things you just said just then. How do organisations actually deal with the increase in numbers that you're finding? Because if they're expecting 51, you've got 350 odd. That's quite a big difference to what they're doing. And because we work so year on year, can you tell me how they manage with that?
That's a great question, Sarah. I actually was having this discussion in Northern Ireland, in Belfast, exactly around resource planning, and saying that, look, firstly, we have this large population of undiagnosed, misdiagnosed, and most unfortunately, miscoded patients that we are finding who should be brought in for care, right? I mean, I did not share this, but for lung and ovarian cancer, we did a study so that just to demonstrate how many more patients are suitable for the Galleri trial that is ongoing in the UK. And for lung and ovarian cancer, we were finding 3 to 4 times more miscoded patients who had been diagnosed correctly, but was simply falling through the net and not even being taken through screening because they were miscoded, right? So obviously, this means that something needs to change, both in the process upstream and downstream from that. But most importantly, resourcing. And going back to my conversation in Belfast, the reason I mentioned it, the oncologists I was talking to over there, they instantly said, well, our nutritionists are being made part-time, or simply, we are having to let them go across the board in Northern Ireland. If we can demonstrate that there are more patients who need care, then it provides us a business case, an actual business case based on financial numbers, to hold on to those nutritionists and in fact hire more. So hopefully that gives you a perspective. This is really helping. And again, I come back to the FDP bid, demonstrating how you can not only create value, but have evidence, data-driven evidence, to plan for your resources better based on existing data. That's the kicker.
Thank you. Next we have Chris Sawyer.
Yeah, Chris Sawyer, Innovation Lead for Digital Health from Innovate UK. Kind of got 3 quite unrelated questions. Just wanted a clarification on the $200 million that you've raised. Was that by Pangaea, or was that the group of your advisors and people involved in the company?
It's me and Professor Guo. We have a large lab at Imperial College that EK actually founded. That is called the Data Science Institute. We have about 80 to 90 PhDs and postdocs there. And this funding came from pharmaceutical companies, non-dilutive grant funding through the IMI initiative in Europe.
Okay, so this project or this business was kind of a spin out from, or output from that research?
Yes, you could say that. Yeah.
Okay. Second question is, are you revenue generating at the moment?
Correct.
You are.
Yeah.
And what type of paying customers do you have?
So we have 3 major pharmaceutical companies who are paying us. All 3 are from the US and the UK, and 3 major healthcare systems, 2 of them from the US, 1 from the UK, who we have revenue from. The one from the UK, of course, is the NHS, which was partly funded through a grant. And then we, of course, have these pharmaceutical companies funding the study further, because, of course, this intelligence helps them as well, like I was alluding to earlier.
Okay. And the third question is quite broader. Potential scale of the business?
Yes. So if you think about, like I said, characterizing patients is the root of everything we do. So at Imperial College, when we were doing our research, we were focused on data transformation, data harmonization, and so on and so forth. So Pangaea, or the idea for Pangaea, did not come from our research, to be candid. But what did we learn was that building large infrastructure and data, harmonizing data, was not very useful unless it helped you answer clinical questions. This is why when we founded Pangaea, completely separate from our research, we said, okay, let's focus on the clinical questions that clinicians are actually interested in answering, both in pharma and healthcare. And let's try to see how we could answer them. And at the root of it came this aspect of characterizing patients. The reason I share that story is you only have to look at how the value that this characterizing patients create, for example, in finding more suitable patients for clinical trials, which on its own is about an $8 to $10 billion market between the US and Europe. How it can help find more suitable patients to be connected to the right therapies, which is exactly squarely falls within the commercial domain of most pharmaceutical companies, which is the big $30 to $40 billion market. And finally, how characterizing patients and building these knowledge graphs with new intelligence helps us find new biomarkers and new drug targets in the context of both genotypic and phenotypic data, which squarely fits within the discovery aspect of pharmaceutical industry, which is the big $15 to $20 billion market. So if you look at the total size of this market just in pharma alone, that is about $60 to $70 billion. In healthcare, you have even a larger aspect of both improving patient outcomes, but doing so in a knowledge-driven way, which can allow you the additional opportunity for collaborations with pharma and funding. And that is something that we have shown through this cancer cachexia work.
Viva, I'm afraid the clock is against us. I feel that we could. Oh, Megan, you've got a hand up. So one final quick question.
Sorry, John, I didn't realise your clock issue, but just a very quick one. From a clinical perspective, it seems like this condition is not terribly easily treated, and that the current treatments don't really offer an increase in outcomes for patients. So do you see this as being something which is more an aid to research and discovery, as you were talking about with pharmaceuticals, rather than a clinical tool at the moment? Or are you finding there's actually clinical outcome improvement with?
Oh, no, there is. I mean, there is a very clear clinical care guideline for cachexia, similarly for COPD, for CKD, for lupus nephritis. So I'm just naming a few hard to diagnose conditions. So there's a very clear clinical care pathway. But because they're hard to diagnose, clinicians have to find these, or they're left to find these patients only if they manually review their entire record to understand what's going on with them. The challenge we're solving here is how to do it at scale and find more such patients who are undiagnosed or misdiagnosed or even miscoded.
Fantastic. Viva, thanks so much for your presentation.
How can we make surgery more efficient? Unless you've been living under a rock, we all know the situation in the NHS is dire. And today I want to talk about a small piece of the surgical journey where I think we can start to unlock some of that badly needed efficiency, the operation note. My name is Grant Nolan, and I'm a plastic surgery registrar and an NHS clinical entrepreneur. So what is an operation note? Well, for the 11.5 million NHS operations, it's the mandatory medical legal documentation which describes the procedure, clinicians involved, and the ongoing treatment plan. It's the principal document for a surgical patient, used by nurses, physios, and other doctors, and without it, everything stops. But just how this pivotal document is written is archaic. Only half of the operation notes are written directly into the electronic patient record system, with handwritten or basic word processing being very common. And ultimately, these are the 5 key challenges with the current format of operation notes. And the result of this is ultimately suboptimal patient care, it's expensive, and it's really risky. We set out to address this, and working with NHS surgeons, coders, UX UI, and entrepreneurs, we created MyOpNotes, a digital note platform that runs within the existing electronic patient record system, and it was built with surgeons from the ground up. And what makes MyOpNotes different to our competitors is we use evidence-based templates to help surgeons write accurately. Diagrams, images, and videos can be embedded directly into the OpNote to make them more detailed than ever before. It's got loads of clever technology built in to reduce errors and omissions and help streamline the process. It improves the OPCS coding, which is currently around 20% inaccurate, and being digital, all data is readily available for export, saving doctors literally thousands of hours of time and giving trust to the real-time data they need to make decisions. If we take a look at the financials, we anticipate the OPCS code generator alone could more than cover the costs and make trust more than the £1.50 per operation note we are pricing this at. With steady growth, we anticipate taking annualized income of 2.3 to 3.9 million in 5 years from an addressable market of 10.3 million. Regarding funding, we've applied for grants to accelerate the return on investment from our sponsor. However, looking forwards, we hope to leverage the data insights and accessibility, which will allow us to scale to other markets, at which point we will be looking to undertake funding rounds. So in answer to our question, MyOpNotes is a digital operation note platform that addresses a single piece of the puzzle, streamlining operation notes for surgeons, capturing all data for research and audit, and enabling hospitals to be better remunerated.
Hi there, Rod Joyce, Deputy Director of Innovation at NHS England. Can you just expand a bit more on the dependencies and integrations with EHRs? Is this integrated into classic big EHRs, or is this consuming the space of the 50% that don't have EHRs?
So we envisage this to run directly into electronic patient record systems, which has been done in multiple countless other times, with PACS being the main example. So PACS is a radiology suite, which it's almost got 100% market penetrance, and it's how radiologists view images and the rest of us view them as well. So that actually runs within a web browser, and it's just the top cut off and put inside. We've designed this exactly the same way. It's a web-based application, and our plan is to integrate it in. Now we're still we've got some pilots signed up, and we've got the APIs set up, so like H7 for getting it back in, and some public APIs, but we're still working on that process, but it's something that we're confident that we can do in time.
Thank you. Next up, it's Megan.
So I think Rod asked my first question. So great work, Rod. Megan Morris-Carter, Director of Digital Innovation for Oxford University Hospitals, and also lead The Hill. I'm interested also in your business model for this. So, do you anticipate being a standalone company? Is this a project within the NHS? Do you want to sell it to an EHR company? Do you want to integrate with PACS? What's your plan?
So, our plan is to create a really, really good product which sells itself essentially, and to get this out far and wide. We're planning to give it away as a 6-month free trial initially, to just get loads and loads of users on board, and loads of hospitals on board. And then once we have that, we'll be generating loads of data. And with that data, I think that's the key to our business model. So there's, we can make enough money selling these operation notes, £1.50 each. But I think the big money is when you start looking at what we can actually do with that data. Data insights into, for example, I got asked recently about what's the market penetration of Integra, which is like a dermal regeneration matrix. We could give them not only here's the market penetration, but here it is on different groups, for example. And then when you build that in with actual outcomes as well, I think that data is like really, really powerful, and that would be kind of the unlocking at a later stage. But the way to do all that is to just have a really, really good product, which is what we're focusing on at the moment, solving that problem for surgeons, which I feel like I deeply understand, and providing benefits to trust and benefits to patients as well along the way.
Thanks, Ron. Next up, it's Chris Sawyer. Oh, sorry, it's Sarah Nelson. My apologies.
That's okay, Chris. You go first.
Okay, Chris Sawyer, Innovation Lead, Digital Health from Innovate UK. Very quick question. Could you talk a little bit about the competitive offering?
Yeah, so in terms of how competitive offering,
your competition, which
yes,
on the market.
So I think the main competition is electronic patient record systems, and I would say the market leader in terms of operation notes within that. So they all kind of do operation notes as a bolt-on. In my opinion. So for example, Cerner has very basic, just text limited options, no diagrams. Epic, that's probably the market leader. You can put some diagrams in there. It will give you some templates, but they're not standardized. Again, there's no way to extract that data, which I think is the key part. And also the cost of Epic is phenomenal, £181 million for Manchester Foundation Trust just a couple of years ago. So we think we can sell this for £100,000 to a large trust. So we can, move the decimal place on this, be an order of magnitude more cost effective for them. And actually, when you add in things like the OPCS code generators, I think it will provide loads of benefit. So I think EPRs are the main competitors. There's no other specialized software exactly offering just specifically op notes out there at the moment.
Thanks, Grant. Sarah, with apologies for that.
Am I allowed to sneak 2 very quick questions in?
Of course you are.
Thank you. Hello there, Grant. I'm Sarah Nelson, Programme Director at the Accelerator at Digital Health London, and also an NHS nurse. 2 very quick questions then. One was related to the EHR and how you were different. You slightly explained that, but I'm just wondering, are you in any organisations where they have an EHR intern at the moment, and they're also bringing your services in? So that's just one quick question. And then the second one is about the cost of £1.50 per op notes. What's the average cost for an average sized hospital in terms of the amount of surgery coming through? Because initially it just sounds like quite a high number.
Yeah, so in terms of where we are at the moment, we've got 2 pilots lined up. So one in Royal Cornwall and one in Kingston, and in the hospital where I'm at the moment, they've just agreed also to undertake this as a pilot as well. So that's in Royal Preston to Lancashire Teaching Hospitals. So we're still in the process of actually getting in and getting on, but we've got all that lined up to do, and that will give us a whole chunk of work and 3 different EPRs to integrate with, and lots of fun there. What the second question around £1.50. So so basically it comes down to that there's not really a set fee or market for this as such at the moment. So we've been looking at what other companies have done. So for example, Concentric, a digital health company, do digital consent. They charge around £1, £1.50 an operation note, sorry, a digital consent form. So it's in that same sort of market that we're trying to align it. But actually the costs really, the economics really make sense, because there's good quality data that says 20% of procedures are currently miscoded by the OPCS coding system. So that equates to about £6 million for a large orthopedic department. So you scale that up, that's like 100 million at least. That's just one orthopedics. There are 10 surgical specialties. Orthopedics, okay, it's around a third of surgeons, but there's easily 100 million there of lost income for hospitals. So, and then when you go into the litigation side, so it's £151,000 for the average cost of litigation. So even if, by using these gold standard evidence-based templates, we just reduce one episode of litigation in that hospital, then it pays for itself. We've got a small amount of gain to improve on that OPCS code generating, which we've already spoken to. We've done some work with coders and we've spoken to them, and they think just having that structured data is going to help them to do it. So, and also speaking to surgeons, that structured template is how we improve things in the NHS. That's a mechanism we know that works, by building in these templates and these things. So I do believe that it will actually make hospitals money, is my fundamental thought. But it's like you say, it's an arbitrary number that we've plucked out of the air. Yes.
Thanks, Grant. John.
Yeah, thank you, Grant. Great to meet you. John, Managing Partner, Rise Asset Management. Just wanted to ask about what's the go-to-market strategy in terms of sort of incentivizing, growing the user base. So I'm kind of thinking, do you have plans to integrate with surgical e-logbooks? What's the value proposition for surgical device manufacturers?
Yeah, exactly. So 3 minutes is really short, so you can't put everything on, but that's one of the huge benefits. Is we want to automate. So autofill, automate everything that we can. We want, and we know from electronic prescribing, the more the less you actually get people to type, the more accurate the actual information you get is. So yeah, we want to integrate with e-logbook. We want to integrate with all of these things like NELA, which is the national audit for emergency laparotomies. All national registries, we want to send the data to them automatically and increase the compliance to that. So we'll save surgeons time. We know exactly, so we've done surveys. Surgeons spend, a third of surgeons spend over 50 hours a year manually extracting data, right? We can solve that. You can just go on and click a few buttons and export this as an Excel spreadsheet. So that there's clear benefits to surgeons to save them huge amounts of time, get on with audits, get on with research, not the boring stuff, actually thinking about them, writing these projects. So that's our kind of go-to-market strategy and the benefits. And from all the work we've done with surgeons, they're absolutely buzzing to get their hands on this. And then for the hospitals, we want to sweeten it with a 6-month free trial. That's our plan there. And then to keep it nice and, we want to keep the price low, so they really feel the benefits of this and want to take it on as a going project. So that's our kind of go-to-market strategy. It's through speaking to surgeons. As a surgeon myself, I'm very involved in different communities, and we've got other surgeons on board to help build that network. And actually, people are coming to us and saying, "Can I use this?" So that's our kind of go-to-market strategy through surgeons up into the NHS.
Thanks, Grant. If I can just put a question myself, is my uploads purely kind of targeting kind of hospital surgical procedures, or is it applicable to kind of more minor surgeries taking place in clinics or GP surgeries?
Yeah, so it's a platform, so it can be scaled to dermatologists could use it for skin cancer excisions. GPs could use it in their own practice for taking off lumps and bumps. It could be used in the private sector. It could be used for like other tests, like camera tests, for example, PCI for cardiology. It's any procedure-based thing where you want to collect data in a structured way, help people write a better procedure note. And we know that these are the really risky parts of medicine, right? When you're putting a knife in people, when you're going into a cannula, that's when things go wrong, and that's when you need that documentation. So Yes, it's completely applicable. We're focusing on surgery at the moment, and that focusing is in a, just on the whole of surgery. So there's loads and loads of applications to this platform.
Okay, great. And just a final question from me. How far have you got with actually kind of building the first version of the platform?
Yeah, so we have a working MVP at the moment. We're just starting to build that gallery of templates. So doing the actual research with surgeons to actually build out those templates. But we have a process where you can build a blank op note at the moment, and we're just building in the templates, because that's really where you get the value through having these templates for different procedures.
Hi, everybody. My name is Mitchell O'Gorman. I'm the CEO of X-Wave Technologies, and our mission is to save lives by ensuring that patients get the best test first. X-Wave is a technology business, but we've got very strong clinical credentials. We were founded by myself and the CEO and leading radiologists, Professor Ronan Killeen, who is the current Chief Examiner for Radiology in Ireland, and Professor Eric Heffernan, who's our Clinical Governance Director and formerly the Chief Examiner for Radiology in Ireland. We're also supported by Anne-Sophie Delaby, who is our Clinical Safety Officer. And the problem that we're looking to solve is huge. It's a global problem. For example, the FDA estimates that between 20 and up to 50% of advanced imaging, so that's MRIs or CTs, can be inappropriate or unnecessary for patients. And this results in poor patient outcomes, such as misdiagnosis, delayed diagnosis, and costs huge sums of money in unnecessary testing. We're the only organisation in the world who have partnerships with both the Royal College of Radiologists and the European Society of Radiology to help tackle radiology backlogs by deploying their guidelines as part of our X-Wave clinical decision support system. So X-Wave CDS gives clinicians the expertise of a radiologist at the point of care with the patient. And it seeks to improve patient outcomes by ensuring that they get the most appropriate test first, reducing misdiagnosis and delayed diagnosis. Reduce unnecessary testing within hospitals and imaging centres to help manage the demand for radiology services, especially in light of increasing pressures on radiology departments, and improve clinician experience by both giving them important information at the point of care with the patients, but also speeding up their workflows. Some of the key features of X-Wave CDS: it can operate via our smart radiology referral platform, or it can be integrated directly into existing systems such as EPRs or order.com systems to supercharge their abilities. Using our cloud technology, X-Wave CDS can also enable smart referral pathways between multiple sites, such as community diagnostic centres or even mobile radiology systems. Vetting is a really growing problem in radiology departments. It takes up a huge amount of radiologists' time. Last week, we were delighted to unveil our new automated vetting solution in partnership with MRAD and GE Healthcare that aims to reduce vetting times by more than 99%. We went live across Irish hospitals almost 2 years ago, and the impact that we've had in that time has been significant. Use of our smart referring and vetting system have reduced the time it takes to send and vet a referral from an average of 7.5 working days to just 15 minutes. So 99.63% reduction. But importantly, preliminary data from a recent audit of X-Wave CDS has shown a reduction in duplicate and unnecessary referring for head and neck cancers by more than 70%. So just this level of impact would save the NHS approximately £123 million per annum in saving on unnecessary scans. So as to the question, if our solution will deliver impact across the NHS, the answer is a resounding yes, so much so that the NHS is now centrally funding the deployment of CDS across England to help tackle radiology backlogs that are only expected to increase with the GP Direct Access programme. All of healthcare involves a form of diagnostic test, and really our longer term vision is to be the gateway for all diagnostics beyond just radiology. And we're currently raising €3 million to further develop our diagnostic gateway to get us to 39 million ARR by 2027. So that's it. Thank you very much for your time.
Hi, Mitchell. Lovely to meet you. Joe Stringer from Octopus Ventures. Anything that improves workflows has got to be a good thing in the current market. However, sort of speaking to a few different radiologists, sometimes the biggest challenge is from your perspective, is go to market. Their doors are being beaten down with every AI solution in the world for every part of the body, combined with workflow solutions such as yours. So how have you approached go to market so far, and how are you thinking about it to reach that kind of revenue?
Yeah. Good questions. So let me tackle the first part of that question first, like whether radiologists will like this. You're right. Most of the AI at the moment is focused on the imaging part of that whole workflow. For us, AI deployed to kind of help, identify patterns, lesions, whatever that might be. For us, it's kind of too late in the process to be deploying artificial intelligence or smart intelligence. Approximately 30% of the cases, it's the wrong test that they're actually deploying this AI to analyze. So actually, there's a bigger problem to solve right back up at the start. This is why we use this phrase, the gateway into healthcare. And actually, there's not much focus being deployed at that part of it. And when you talk to radiologists, obviously, which we do, and we're founded by radiologists, the work that they like doing is the looking at images and the reporting, and that's what they're trained to do. So anything that can be done to actually reduce a lot of the mundane or low value tasks in their workflow to free up their time for those high value tasks is an absolute godsend for them. And that's exactly what we're looking to do, with both making sure that the referrals that come into them are high quality, but also enabling that auto vetting solution that I talked about. It takes an average of 2.4 minutes for a radiologist to vet a single referral for advanced imaging. They could be doing hundreds of those a day. And so actually when you deploy clinical decision support in the vetting process, the way that we're doing, you enable automated vetting. Like if it's green, it goes. If it's amber, that's the ones you need to look at. If it's red, it gets an automatic rejection, and actually free up their inbox. So that's the real benefits to radiology teams. As to the go-to-market, we are in a very fortunate position that the NHS England is now funding this centrally. So actually, that's really accelerated the conversations that we've been having. Previously, the Royal College of Radiologists had an exclusive relationship with really our only competitor in the market, a Canadian company called MedCurrent. And now that the NHS is funding it, they didn't want to fund a monopoly. So they've invited us into the market because we're already live, obviously, in the adjacent Irish market. And we have had a significant level of interest from imaging networks and ICS level, and we're kind of currently working through converting those because the money is available to them. And this is a really high priority for the NHS because, as I said, radiology backlogs were already bad. There's a 29% short across the UK, according to the RCR. But now GPs are being given direct access to advanced radiology for cancer pathways. NHS England expects that this will actually double the demand on radiology services, which are already under pressure. So they have to be underpinned by clinical decision support.
Hi, Mitchell. We lost you there for a second.
Yeah, sorry. When you realise I'm the only one moving and everyone else is frozen, it's like, oh no, that's not me. Sorry. I hope you caught all the end of that. I was finishing up.
Yeah, thank you. Yeah.
Referral program. Yeah.
Next question, Sarah Nelson.
Hello there, Mitchell. I'm Sarah Nelson, Programme Director at Digital Health London's Accelerator, and an NHS nurse who's had many 3 a.m. conversations about imaging. So yes, very interesting. Thank you. My question's about this central funding that you were just mentioning, actually. Yeah. If you've got the central funding coming from NHS England, what made you decide to come for Pitchfest this year?
This has all happened very quickly, Sarah. So number one, the NHS funding has kind of because we didn't previously have
Mitchell, unfortunately, we've lost you again. I know it doesn't do much for the kind of video recording, but perhaps if you were to drop out video and try audio only.
Would you like us to turn off our videos as well, just in case that makes any difference?
Usually that doesn't make a difference. It's usually kind of his end or the other end. But I fear if he's got a flaky connection, this is going to be a recurring problem.
So he's dropped off the call completely, and he's coming. Oh, he's back. Okay.
Apologies, my Wi-Fi is having a nightmare. I'll just keep my video off, and if it goes again, I'll jump in on my phone. Sorry, Sarah. I'll try and speed up my response to that question. I was Rewired, I think, is a fantastic event. I was there last year. We're actually exhibiting at it this year, and it gives us a really significant opportunity. We already have meetings lined up with ICSs and imaging networks to kind of talk about our solutions. So I think it's just an excellent platform. You know, we're still a startup. We're fortunate that there is all of this funding available to us. But you know, our challenge now is getting the word out about what we're doing, letting you know, ICSs and imaging networks know that there is an alternative available, and really what the benefits of that alternative are. So I think Digital Health Rewired is an excellent platform to get that message across.
Thanks, Mitchell. You'll certainly not get any argument from me on that one. John, you're next.
Thank you, Mitchell. John, Rise Asset Management. And just really kind of going at the sort of the value proposition, just to define unnecessary imaging. Are we saying unnecessary in terms of, you know, no findings, or kind of no indication for the imaging at all? And then if it's no indication, who takes responsibility for sort of saying it's unnecessary? So obviously you're kind of aware that, you know, sometimes in clinical practice, you've got sometimes kind of, you know, clinicians are kind of seeking assurance, and so it's a little bit borderline when they're requesting some kind of images.
Yeah, that's a really good question. So there's two elements to, let's say, an unnecessary test. One is that it's inappropriate. So it's actually the wrong test for the patient. So for example, they should be getting an MRI brain with contrast instead of a CT brain. And typically, you know, those patients might have to go through a whole gamut of a series of tests before actually the most appropriate test. So that's the first one. The second one is low value, where they probably shouldn't be going for a test. And again, you know, there is this use of defensive medicine to kind of you know, over image just in case. And you know, for me, in a perfect system where there was no backlog or you know, over demand on scarce resources, that could be fine. But actually, where you are sending somebody for an image and it's not needed and it's not the right image for them, you're also denying somebody else who might need that image. So who determines whether it's low value? At the moment, it's kind of done on an ad hoc basis between the referring clinician and the radiologist who receives the referral. So that's what the vetting process is. It's there to say, no, this isn't good. There's not enough clinical validation to do this test. But actually, because the systems are so broken, they just let it through. They'll never talk about it publicly, but let's say, look, it's easier and quicker for me to do this test and then go back and say, hey, we found nothing, do this other test, and then push back. And again, it's another really valuable aspect of introducing structured clinical decision support into that decision-making process. So it's a lot more transparent and clear to both the referring clinician and the vetting team as to what is appropriate and what is needed and what's not. And what are those kind of borderline cases? You know, if you look at traffic light system, green, good, amber, maybe, and just have those conversations around those maybes, but certainly take out the kind of the green and the red element to it as well at the vetting process.
Thanks, Mitchell. Next up, we have Rod.
I'm Mitchell, Rod Joyce, Deputy Director of Innovation, NHS England. My question was around, you know, adding more. There's more and more products coming into the market every day, and being able to say which products to integrate. As a CIO or a commissioner, how are you helping them fit this into their world? You know, so you're saying that we're very much going upstream, we're not looking at the AI imaging. So it's like, as a commissioner, I'd be thinking about, I'm having to plug multiple systems in to do different things. How are you looking at working in partnership with people, understanding how you create a more holistic sort of solution as opposed to in standalone products? Yeah.
So Rod, we started off by like developing our own, you know, smart radiology referral platform, and we came to market and soon realized that, you know, even though it's better, doesn't mean that it's going to be adopted. And really the value that we were bringing was the clinical decision support. So early on in our lifetime, we're only, you know, going since 2020, early on in our lifetime, we kind of made that pivot to actually what we're not providing a smart radiology referral platform. We're providing clinical decision support as a service, and we need to be platform agnostic. So sometimes there will be a case for our platform. So we have, you know, group of GP providers that are still using paper-based pathways, and that would obviously benefit from a digitized pathway, and also enabling pathways out to community diagnostic centers, as I mentioned, or mobile services. But in other cases, they're all using, for example, Clinisys Ice, right? That's the biggest order-com system in use, connecting kind of primary care into hospitals. So we're currently integrating now into Clinisys Ice to make that available as part of their ordering system. So it is that partnership approach by working with existing systems, so that we're not dramatically asking people to rip up the systems that are there, and we're enabling that. And again, important for us was to build our platform on AWS Fireworks, so we have that Fire HL7 interoperability in place to enable those integrations to happen a bit more seamlessly.
Thanks, Mitchell. Question I had, Mitchell, was so incredibly fortunate and well done on getting NHS England funding for the platform. I presume that's across England, not Wales and Scotland as well.
Yeah.
How long is the funding for, and what happens when that funding ends?
So it's an initial, typically we would be funded for a 3-year deployment, and the funding programs are to run up until 2025 initially, and obviously they'll look to see whether they're going to continue it. And actually there's now 2 streams of funding. So there's the digital diagnostics program, and there's also the GP direct access program that the funding is going to come out of. So what happens after that is either it'll continue to be funded centrally, or those organizations that are already using CDS will look to see if they're going to continue to pay for it themselves. And again, that decision typically will be made at ICS or imaging network level. We have obviously very robust data and analytics suite that can show, you know, dynamically the impact that this is having. For example, you look at the change rate, where a clinician would have ordered one test and saw the clinical decision support and actually changed their mind and ordered another test, or actually didn't order a test at all. So we have some really kind of hard metrics that we can use to kind of show the impact and the kind of ROI of the deployment of the platform that helps to make those decisions a bit easier.
And sorry, just on the same, so given the 3-year kind of funding you have, where's the market opportunity in the English NHS for additional sales? Is that sort of clinical imaging networks and ICSs? I mean, what are they buying separate to what's being funded nationally?
So what they're buying is the clinical decision support element that we provide, either integrated into another system or delivered through our system. That's the first thing that they're buying. The second stage that we've just talked about is this deployment of smart vetting. So, I mean, for us, you know, from a commercial perspective, it's an upsell, because typically clinical decision support is just used at the point of referring, right? Let's give it to clinicians who aren't radiologists, and nobody's really thought to give clinical decision support to radiologists, because why would they need it? Because this is what they studied, so they all know it. But actually, when you deploy clinical decision support and vetting, what you're doing is, number one, you're democratizing the ability of anyone on the radiology team to vet, because they're doing it against standard guidelines. So it's not just falling on the shoulders of radiologists. Actually, anybody on the radiology team can now vet. And number two, what you're enabling is automated vetting. Green it goes, amber it needs to be questioned, red it goes back. So that's another opportunity for us to bring greater efficiencies into the system. So that can operate as a standalone. In fact, what we can do is we can deploy that into a risk system, which is typically where vetting happens, or into a PAC system. So that's why GE Healthcare and a couple of the big PACS providers are looking now to partner with us on the deployment of this smart vetting solution. Beyond that, we're also, which I haven't, because I didn't have time to talk about, we are building the next generation of kind of clinical decision support, which is using natural language processing to learn about patient outcomes from radiology reports, and actually to be able to determine statistically what are the best tests for patients, statistically what are the most likely outcomes the patients will have given their clinical indications. So at the moment, clinical decision support is based on experts, but actually it's not based necessarily on data and outcomes. So when you can actually learn about patient outcomes, you can use those outcomes to bring it back to the start and improve your inputs.
Mitchell, I'm going to we're up against the kind of clock. That's been excellent. Thanks so much for your presentation.
Hi, I'm Raj. I'm the co-founder of Health Tech One.
And hello, I'm Lydia. I'm founding clinician.
So Health Tech One exists to automate admin tasks in the NHS. But here's a fact that we often forget. Behind every clinician, there's an administrator who's burning out with a backbreaking to-do list. They are the unseen other half who do the silent work to keep the NHS running with an enormous impact on patient care. An example, last month, a practice in York actually shut down because of receptionist shortages. And across the NHS, we're 10% short of staff. And the answer isn't recruitment. It's technology. Let's strip out the paperwork that plagues our teams. Let's automate our admin and let's empower our staff to do more with less. And by doing so, we open up a big opportunity. Every year, we spend 1.9 billion on administration in primary care, billion. With today's technology, 65% of the work can be automated, opening up a 1.2 billion market opportunity. And guess what? The secondary care market is 5 times larger. And that's where we come in. My co-founder, Pete, and I left Monzo and Accenture to start a growth agency, but were shocked into action whilst helping my parents' GP practice during the pandemic. And bounding out of Accurix, an entrepreneur first, Dr. Lydia has joined us along 2 other incredible individuals, and together we're building an automation platform to plug the NHS staffing gap.
But like with all big NHS visions, you've got to start with something that delivers immediate value. So our first product, Sani, named after the registration clerk who taught us how, intelligently automates registrations all the way from first patient contact through to consistent data coding, right through to the first patient care tasks. Patients are registered same day compared to previously waiting days or even weeks. We're now paid to work with 70 practices, and with over 26,000 registrations under our belt, we have already freed up thousands of hours of staff time. This month, we'll do 1% of the nation's registrations. We've gone from new kids on the block to being backed by the nation through a £450,000 Innovate UK grant to automate recall, screening, and record transfer. Plus, we have 2 other NHS-funded projects on the go. We're now the market leader for primary care automation, all of that within a year. Finally, we'll let you into our secret advantage. We work out of a GP surgery, so if we need wise insights or the answer to a simple question, we just pop down the corridor. I'm also a GP. I've spent 15 years working and training in the NHS and a fair time in health tech. I know that our competitors are obsessed with building tools, but GP practices don't need another tool with another set of logins. They need one less task, and we're one of the only companies that actually removes work from the shoulders of primary care teams.
So the ask, if we win, we want to meet the admin staff at CW+, actually meet the teams. But to you, our dear judges, and anybody watching this, a vision this large can't be done alone. We need your help. We want to be introduced to innovators, investors, and leaders who want to shake up primary care. So help us to help the NHS, one task at a time.
Hi there, both. Rod Joyce, Deputy Director of Innovation, NHS England. Thank you for the upbeat pitch for one of our last ones. It's helped. My question was, again, around your competitors. Right? There are established players in this market, from Blue Prism and UiPath and Layer and various others who are trying to come into the market too. How are you, I get you're differentiating in the primary care space, but where do you see your growth?
Yeah, I mean, largely our growth will come in primary care to start off with. And the reason why is that, like we say, we're in a GP practice. So how we differ from Blue Prism or UiPath, etc. What they do is they provide a tool for clinicians to automate their own work. They've got to design their own processes. They've got to build their own flows. They've got to deal with their own IG, security compliance, all of that sort of stuff. And what we do is that we do all of that work, right? We do all the process mapping, do all the flows, we capture all of that. And then what we just literally give it to GP practices as something they can just buy, right? So like off the shelf. So it becomes very easy for them to automate their work. Onboarding takes, literally 2 days.
So are you dependent then on GP systems like EMIS TPP for integration, or you?
So yeah, we use a different type of technology. It's called intelligent automation, and the back of that is RPA. And what we're able to do is use the user interface of the clinical system. So it's agnostic to a particular provider to input the data into the clinical system. So that's how we get the data in.
Okay.
Thanks. John.
Yeah, no, thank you both. John, managing partner at Rise. So it's really around the value proposition, perhaps to the practice managers. I'm sure you know very well. What is sort of the greatest area? So you kind of talk about QoF, talk about a few other things, but what is what are you generating revenue off the back of currently?
Yeah, I mean, so the first task we did was automating patient registrations, right? And there's a reason why we did that, right? Is that it's a really big driver of income for the practices. So GP practices make most of their income from the capitation fee or their list size. So, you know, increasing, they get £100 per patient per year on average, right? So, you know, increasing that, you know, the list size of a practice by 1,000 brings in an extra 100,000 in revenue, right? So it's very tied to that. So that's quite compelling measure. So there's income generation on that side. There's also just staff time saving. So there's a huge amount of time that's spent in registrations. So we're able to strip that out. And then the other is kind of actually improved outcomes for patients, right? Things that automation do, which is speed, the work getting done really fast. The clinical safety uplift that comes with automation, the accurate the coding that comes with it, the complete stripping out of human error. All of those things.
And on the point of value as well, you know, you mentioned QoF. QoF, obviously you've got to have your denominator and your numerator, and you want to increase the denominator, but only if you can also improve that numerator as well. And so what we're doing is, yes, we're getting those patients into the practice, but we're improving the coding so that you can search those patients better to target them for QoF. But also we're even doing things like, if someone says that they're a smoker and they want smoking cessation advice, we send them some information about smoking cessation. So we're trying to, and we code that. So we're trying to help them hit those targets, which is also obviously associated with money as well. So yeah.
Totally.
Thanks, Chris.
Yeah, Chris Sawyer, Innovation Lead for Digital Health from Innovate UK. What you're doing seems to be working really well. Just want a little bit more information about your sales and marketing strategy.
Yeah, sure, definitely. So I suppose how we grow is split into 3 different phases, right? Is getting to the first it was the first 10 customers, right? Then it was getting to your 100 practices, then it's getting to 1,000, and then it's taking the rest of the market, right? So the first 100 practices, we're kind of at 70 at the moment, which, you know, with just the rest of our personal networks, we'll get to 100. So using the stuff that we've got already, getting from 100 to 1,000, what we're going to do is we're going to offer additional bits of the product, taking the Acrix playbook and evolving it, offering additional bits, like, for example, GP to GP transfer, which is the record from one GP to another, is something that we can quite easily do. And it's something we can say to GP practices, hey, look, we'll give you this product and it will help us boost, but please refer us.
Yeah, referral incentives, basically.
Totally.
Yeah.
And then getting to the big jump from 1,000 onwards. We've actually kind of devised quite a few strategies on this that we've been planning for a long time. So one of them is that we released a web page for every single GP practice in the country, and this is like it's like a landing page that is really search engine optimized, that kind of tracks up to the top of Google. And it's one of those things where what we can do is it will have like a registration button, and what you can do is that you can use that to start to divert traffic to various practices. And that's a way in which we can increase list size for practices, but also tie that in with, hey, we've got a bunch of patients that would like to register at your GP practice.
Thank you. Sarah.
Good morning to you both. Sarah Nelson, Programme Director at Digital Health London. Nice to see you. Do you have any patient feedback? I can see the benefits to the GP practices, but patient feedback, and specifically if there's anything around the automation and accessibility side of things.
Yeah, totally. So when we first started our kind of product research, always involves patient feedback. So we had 38 patients in this very room. So it's a very long room in a GP practice, right? So in Stratford Village Surgery, we had 38 patients in here from ages from 18 to 80. And we got their involvement in the design of the product from the very, very beginning. And throughout, we have a constant touch point from patients when they complete like the registration. So we're kind of ranked or rated 4.57 out of 5, right? So we've got constant feedback. That's over like maybe 4,000, like more than that, 10,000 results or something like that.
Thank you. And next up, it's Joe.
Oh, I think.
Hi guys, lovely to see you again. Yeah, congrats with progress over the last year. Have you just around your sort of sales strategy, have you started targeting any of the bigger primary, because my constant fear is your cost of sales. You know, if you're going practice by practice, you're going to soon sort of run out of headroom. So have you managed to approach any of the bigger primary care groups or the ICSs to try and do something at a larger scale?
Yeah, sure. I mean, take one of our clients already live is a Nexus Group, right? And they're based in Southwark. And there's about, I think there's 9 GPs. Yeah. They're all grouped into one. They're one of the largest GP practices or practice groups in the country. And actually a client that paid all up front because they were like, look, we can see the benefit. We went in and met the teams. And actually, you know, there's a really nice stat actually by just doing 10% of practices do 25% of all registrations. So yes, going after those like larger groups is totally within our strategy.
Yeah, but also thinking actually more, not just on the sort of practice groups, but also federations. We've actually found is a really, incoming interest from federations. Actually, we're already working with a federation, but also, hope we're sort of going through the process of just sort of completing stuff with another federation. I think what's really nice about those groups of practices is that they not only get the benefit for each individual practice, but they're also beginning to see things on across their patch, not only consistency and standardization, but also actual population health data or information that's relevant to population health data, these things like ethnicity being coded really consistently. So yeah, definitely federations and groups of sort of 30 to 50 practices in a go is one of our strategies as well.
Totally. We've had so much interest. That particular customer segment, GP Federation, had a lot of interest from them.
Cool, thank you.
Thank you. You spoke about kind of taking the AccuRx playbook, and Lydia, I think you were employee number 2 there.
I was, yeah.
Well, can you just kind of unpack that a bit? What does that mean in practice? What comes after SAMI and patient registration? I presume that you're not kind of trying to kind of challenge TPP or EMIS head on to become primary care kind of EPR, but to attack discrete bits of that market?
Yeah, I think there's a few different things actually. I think what we were referring to there was in terms of that gamifying referrals and that growth, that real accelerated growth. I think that AccuRx really, showed a lot of us how, that I was part of that, But I think there's a few things that we'd also do differently. The fact that we're a paid product actually already, and that's really nice for us because we found product market fit. People see the value in what we're doing for them, and that's really fantastic. But also kind of in terms of what AccuRx did really successfully was the ground up approach, going to your users, getting champions from practices, solving a problem that people are facing every single day, almost every minute of every single day, and showing them that you could release immediate value. And these are all things which I think stood AccuRx, and the team at the time in really good stead. And yeah, definitely happy to do that, but just as Raj says, evolve it and make our own journey, I guess, off the back of that. Yeah.
Totally. And to speak wider to the kind of longer term vision, right? We think, yes, EHRs are, a lot of people trying to create EHRs, but on top of those, there will be automation platforms as well. So, an example of that would be Notable Health in the US, and they're an automation platform, having a lot of success. And it's not, yes, patient registration is a beachhead market, right? That's a 14 mil market. But actually in recall and screening, there's a 120 mil market. In coding of documents, there's a 130 mil market. And even just the collation of prescription requests from multiple sources, that's 102 mil market, right? So there's just so much. I mean, let's break down a practice, right? We've got, we process map the whole practice. There's about in a single practice, 127 tasks. 107 of those are administrative tasks, right? So there's just so much scope. Patient registrations is one of them. So there's just so much scope in general practice to do this kind of work. And you've got to remember, right, if you look at the staffing ratios, 44% of every staff member in GP practices are administrators, receptionists or secretaries, right? 63,000 people. So it's just like, there is huge amount of scope here.
Lovely to meet you all. Today I'm going to talk to you about Gout Scout, which is a application that I've created to help people manage their gout. So a little bit about me. I'm the co-founder with my co-founder partner Mick, and I've lived with gout for about 12 years. And here's some lovely photos of what my gouts look like over time. It has indeed rendered me disabled on many occasions. Has had multiple impacts on my mental health, my career, the care that I can give to my child, all sorts over a multitude of years. And after being prescribed with drugs over time and told different ways to manage it, I thought there was a way to do it differently and to better understand my risk factors myself and to manage my lifestyle. So ultimately the mission for us is to help people who also suffer with it manage and live with it in the best way possible, and gout presents its way in many different painful forms. In terms of the landscape at the moment, there's 41.2 million gout sufferers in the world. Around 7% of those, there's a 7% increase during the period of 90s to 2017. 1 in 40 adults are affected to some degree. And there are lots of people who are actively seeking help, and lots of the treatments are outdated, and there's loads of media around this as well about the growing prevalence of gout. In terms of the current therapeutic landscape, as you can see, a lot of it is drugs based with some of the key manufacturers there, and the value of that market is due to be 8.3 billion by 2025. And when we look at the medication that I've taken, that many others have taken as well, when you look at the Institute of Care Excellence guidelines, these are considered to be lifelong medications that can only be stopped at the point where people can successfully manage modifiable risk factors. So I actually did some surveying to ask a sample of people how many of them are actually still having gout attacks and pain even though they're taking those medications, and we had a large percentage, 68%, said that they still receive attacks. And looking at ways in which people would prefer to manage their gout as well, lots of people have highlighted that they prefer to manage it through lifestyle modifications or through a combination of their medication and managing their risk factors. And also when speaking with rheumatologists around this space, they've got a variety of different goals that they like to achieve. But ultimately, they said they'd like to spend more time with their patients to be able to coach them through what they need to be able to manage their way out of the condition that's leading to their gout flare-ups. So that's where the application comes in. We've created a variety of ways for people to manage and track the different risk factors that are associated with gout, to understand whether or not they're on the right pathway towards a future attack, or reducing the prevalence of attacks over time by measuring their gout attacks, the frequency, the pain against other risk factors, in addition to a medication log, as well as their BMI, and other factors of their health. And we also have a social community section as well for people to support one another, as well as understand things such as their diet and lifestyle intake as well. In terms of user feedback, we've had lots of positive user feedback as well around this, and yeah, that's a very brief 3-minute overview of Gout Scout and what we're trying to tackle.
Fantastic. John and then Joe, I think.
Yeah, thank you very much. Yeah, great to see you. And John, managing partner at Rise. I just wanted to ask around sort of the revenue model, particularly kind of the value proposition of the premium subscription. Could you just expand a little bit more on that? Yeah, is this something that you think you could get into, perhaps timing, events age, getting into kind of dosing, type kind of recommendations, whether that's kind of through a clinician?
Yeah, so I've been looking at the different potential revenue models around this, and I think originally the premium model was there to try and ascertain, will people pay for it out of pocket in a direct-to-consumer model, for example. At the minute, uptake of that has not been as high as initially anticipated, and I think given the current state of the market as well, looking at all sort of paid health applications that I've sort of worked with directly or with others in my consultancy life, I think the impacts of the economy certainly have an impact on that direct-to-consumer model. You know, you see Noom, for example, having an impact on their intake. So the alternative options that I've been looking at have been around the health data itself and how it could be supported, how it could be used in order to support new drug development, new drug discovery, to support the pharmaceutical industries, for example, with having post-market surveillance in more of a frequent basis, which is a very big, costly exercise that pharma has to go through in order to understand. Well, they normally only ever hear about the negative stuff. Getting the sort of positive use cases of recovery rates as a result of medication in a more real-time format would be of use. So when I showed you that gout therapeutics landscape model, part of what I'm aiming to do here is to be able to partner with the manufacturers of the different therapeutics to better optimize the products that they're creating, but also to be able to provide a sort of data platform, as it were, back to that side of the industry. When we're looking at the NHS directly as well, though, in direct to care, there is this ambition, of course, one day of digital therapeutic prescribing, in which case I think the application would be well positioned for that. However, until that time properly comes, I think at the moment, very much looking to have it the model where it's propped up by industry, therapeutics manufacturers, that sort of thing, but to make it forever free for the users. And then, yeah, if the model changes around an entry point with the NHS, then we'll be in a prime position to be able to support there, because it does save a lot of clinician time and management and whatnot, as mentioned from the rheumatologist perspective.
Thanks, Randall. Next two questions from Joe and then from Chris.
Hi, Randall. Joe Stringer from Octopus Ventures. Thanks so much, and you definitely win best name of the day. You started answering the question, which, you know, given a magic wand and, you know, hundreds of millions of funding, where would you take the product? Because there is an argument to go down the digital therapeutic route. I agree with you that, you know, direct-to-consumer premium apps is a bit of a minefield at the moment. But where would you love to take it?
Well, I mean, like, so if we're thinking like big long-term vision, in my mind, the way it currently goes with the treatment pathway for gout, or at least the way I've received it and the way it seems to be the common story, and looking at the guidelines as well, is that the actual testing around gout, for example, is quite broad scope, and then you get put on this lifelong medication fairly soon after you've been seen as having high uric acid for a period of time. In my mind, like, and one thing that the clinician, I remember when I spoke to GPs before, you know, they give it a bit of time before they give you the medication to see if your uric acid level dips or if anything improves in your lifestyle. But they don't have the time to give you the resources or the information or the content or anything else. So really the first line therapeutic should be some sort of a coaching thing, or some sort of a way for people to self-manage and understand what their risk factors are to try and prevent them having to go on this lifelong medication. And in my head, I would see Gout Scout as the first line therapeutic that a clinician could say, okay, well, I don't have time to coach you, but here's a thing to go use. I'm better to understand your personal risk factors, and then be able to, you know, get yourself off of the negative pathway before needing to be put on the medication. There will always be cases where people need medication, where there's chronic conditions. There's things like, you know, cancer patients who have gone through therapy, through chemotherapy, it throws everything off balance, and then the uric acid levels go up, and then they have to be prescribed with it and all sorts. So there are unavoidable paths, including sort of genetic stuff. But ultimately, I'd like to see Gout Scout as the first line therapeutic for helping people manage that particular condition. And then it could go on into other inflammatory disease areas in the future as well, given that this is quite a hot one. Yeah, and if funding were to sort of come to me now, well, ultimately what I'd be looking at is how do we drive up, continue to improve the data platform in the back end, and how do we drive up user uptake and adoption, make people aware of it, keep it as a free model for now, build that user base, build the database, and then create a nice value proposition for the industry to say, yes, we'd like to invest in that because we're going to get useful insights to interact with this particular user group as well.
Thank you.
Thanks, Randall. Next up, we have Chris.
Yeah, Chris Sawyer, Innovation Lead, Digital Health, Innovate UK. Along very similar lines, what are your, on a commercial perspective, what are your challenges to success?
Challenges to success at the moment. Right.
Or even longer term, or even longer term.
Longer term. Okay. So challenges to success longer term. I think one of the big things around it, okay, so longer term challenges to success will be, I think one is around territories in terms of where we actually try and drive user uptake from. At the moment, the application's available worldwide. We do have a lot of users in the US. I think part of it will be the longer term is setting ourselves up commercially within the right territory to be able to maximize revenue from wherever that may be. If we're going to work with pharma, US is the place where we need to be. I'm UK based. I don't have the time and energy right now compared to everything else that's going on to be able to set up an entity in the US and to be able to grow there. So I think that's going to be one of the big long-term challenges. And then ultimately, I think going forward as well, like if we think about the trajectory of health applications, there's lots in the market at the moment, whether this becomes a standalone thing versus something more integrated. Getting into a position where we can integrate better with something like if it's going to be the NHS app in the future or whatever else, depends on again which territory and jurisdiction we look at. I think being able to prevent this just being another point solution, I guess, is one of those, and staff as well. Like the one thing that's always going to happen here at the minute is it's just me. I'm a contractor with a few gigs at the minute, and having enough people to run off and actually do things for me at the moment is another thing that I'd love to have. But yeah.
So that was my other kind of question, was how many are there? And it's just you.
Yeah, so it's me. I've got my co-founder Mick, who he's the engineer that I've worked with historically on other products. That's why we sort of get on. We've got a designer and 2 back-end developers as well working with us, but it's all engineering focused. The sort of commercial aspects are sort of coming from myself, and I think, as I mentioned, I'm just doing a project with Pfizer at the minute that I've deployed this week. But I've got looking to grow more relationships within that space so that, I do all the commercial activity at the moment. But if I had, again, that network or the ability to access others like that, that would be useful as well.
About building the team and everything that's around that. Yeah.
Yeah,
okay.
Exactly.
Great. Thank you.
Thank you. So, Randall, just picking up on that, have you got experience of working with pharma companies on other projects then? And, is working in the digital health space something you've got experience of?
Yeah, so I was the product director for the NHS COVID-19 app back at the top of the pandemic, which is by far the biggest application I've ever worked on. Like a third of the UK's population were using it at one point. But we had, literally last week this week, deployed with Pfizer and Ada Health. I don't know if anyone's aware of Ada Health, but we've developed a telehealth application whereby we've got telehealth prescribing services in the US now based around COVID antivirals, but also eligibility screeners to understand whether or not somebody is eligible for treatments based on health risk factors. So yeah, I've got, my history is in the digital health space, my experiences in that, and yeah, I'd say this is what's currently keeping me busy at the minute is Pfizer, but I've got other things I've worked on in the past, including NHS projects.
Brilliant. I'm sure there was in your application, but thanks for kind of refreshing. Okay, I'm afraid time is against us, so I'd like to thank you for your presentation, taking questions from the judges.